All right, good afternoon, everybody. Thanks for joining us here at 30 Minutes on Healthcare Reform. This is a 5-part series sponsored by Corporation for Supportive Housing, the National Alliance to End Homelessness, and the National Healthcare for the Homeless Council. As Medicaid changes are proposed in state-by-state conversations, we want folks to be aware of what those changes are, what the impact will be for the people you serve, the coverage and healthcare needs of the people you serve, as well as your agencies and your communities. We're going to talk today about Medicaid expansion and how state Medicaid agencies think about eligible populations. So thank you all for joining us. This is session 2, as we said, of the 5-part session. So we'll move forward. Here is a map where you should be able to find your state. Map is about 2 to 3 days old. We think it still looks good. We have 32 states, including the District of Columbia, have adopted the Medicaid expansion. Other 19 states are not adopting the Medicaid expansion at this time. So you can quickly see here and find your state. Kaiser Family Foundation, the link we'll send out with the slide deck will include it, and that Kaiser updates that on a regular basis. It's important to know that the states think separately about what they call the Medicaid expansion population, and they think about it separately and differently than other populations for a couple of reasons. One, right now, in 2017, they're getting a significantly higher rate from the federal government. So through 16, for the Medicaid expansion population, people who were newly eligible because of the changes made in the Affordable Care Act, the feds were paying 100% of the cost for those individuals. In 2017, that decreased down to 95%, so the states needed to pay 5% of the cost. That's still a pretty good deal for states. If Affordable Care Act is not changed, that will decrease a couple of percentage points until we get to 2020, when the states are paying 10% and the federal government is paying 90%. Still a really good deal here for states. And we'll talk about how a couple of different states have done this in an affordable and what they call an alternative model. But for now, this is the states that have expanded that haven't expanded. So when states talk about the Medicaid expansion population, they mean very specifically people who are eligible solely because of changes to the law and changes of eligibility related to Medicaid. These are individuals who don't have to have a qualifying disabling condition or other such detail. They just have an income below 138% of the poverty level. With the election, please know that some states are discussing Medicaid expansion. Deep red Kansas, it passed the legislature. It was vetoed by the governor, just short of being able to override that veto. North Carolina switched from a Republican governor to a Democratic governor who actually campaigned on Medicaid expansion. He supports it, but there are challenges with the legislature there. The Virginia governor, Terry McAuliffe, has been requesting Medicaid expansion since as soon as he came in office, but that can't get seen through the legislature. And it's interesting to note that there are unique coalitions that are coming to support the Medicaid expansion. Texas Chamber of Commerce is actually supporting the Medicaid expansion and engaging their legislatures around that. Various business groups, hospitals and other large healthcare employers obviously want the Medicaid expansion, but research is showing that states who do expand Medicaid, if for the bottom line of their state, whether it's for state revenues, the healthcare of their people, or just how people are able to become an entrepreneur and open a new business because they may have a short period of time with very little income, they can get Medicaid for that time. It gives them some unique opportunities there. So look around, there are unique coalitions and communities that are supporting the expansion. But as we think about what can still happen, I like the Charlie Brown cartoon. We were all very happy, I think, the day that AHCA was not passed or not even voted on, et cetera. But it just seems every day there's a new proposals being put forward, new healthcare language. Right now, people in health policy circles are talking the MacArthur Amendment, which is Tom MacArthur is a Republican from New Jersey who's part of the what's called the Tuesday Group, the moderate Republican force. He's negotiating with the Freedom Caucus, Mark Meadows, to try to see if there's something that both of their caucuses could support moving through the House. There are other things that can still happen. We'll talk about them today. Work requirements, cost sharing, and I'll talk about what that means. Eligibility, how people become eligible, why people become eligible. Indiana, in one of their waivers, lost NEMT, non-emergency Medicaid transportation. If folks are on Medicaid in your state and they need to get to doctor's appointments, things of that nature, that's often possible through Medicaid support. Indiana lost that in their last benefit. The other piece is that the individual markets could collapse. Different parts of the healthcare world could be challenged. Healthcare insurance companies, health plans that are in the individual market are very, very concerned. There's some major concerns out here in regard to what are called the cost-sharing reductions, the subsidies that lower income people get. These are usually the working poor individuals that they get are not assured for 2018, and obviously that if the insurance companies don't get these cost-sharing payments, cost-sharing reductions they're called, they're going to have to pass those costs on, either to consumers or providers. We'll talk about that. And then open enrollment and outreach, how much the federal government or how much the states push to engage to make sure that people get insurance, that they know that they're insured, that they consider their coverage, and sign that up every year. People don't do that. Very interestingly, the Trump administration stopped some of the, when they came into power on the January 20th, stopped some of the outreach and engagement activities. So these are just some of the things we'll talk about today where open enrollment and outreach can change, can still happen. And next slide. This is from last time as well. We talked about when states have to save money, what do? They limit the population served, and we'll talk about populations today. They limit benefits offered for certain population groups, and we'll cover essential health benefits and the impact of that in an upcoming webinar. They also pay providers less, even though Medicaid historically has low rates on coverage. So that means that if providers may say it just doesn't make any kind of cost sense in order to continue to serve people on Medicaid and come out of the network. A lot of concern that the provider networks will be even more limited for individuals if the states pull the rates so low that it just doesn't make financial sense for them to continue to offer services to individuals on Medicaid. But today we're going to talk about populations. Medicaid has had historical three what they call federal core populations. Those populations include our first picture, pregnant and parenting women, our second picture, seniors, low-income seniors, and our third picture looking at some of the aged, blind, and disabled population. These are populations that the federal government pre-ACA must offer services to, and we'll talk about what some of those services can and can't be, optional benefits, et cetera, in an upcoming webinar. But these are the federal core populations they must serve: pregnant and parenting women, low-income seniors, and you'll hear this phrase again and again, the aged, blind, and disabled. If you work with individuals that are on supplemental security income or SSI or SSDI, they should be in that aged, blind, and disabled group. And then we have our third population, the Medicaid expansion population, what people will also call the able-bodied population. Interesting point to put forward is that 60% of those who signed up for Medicaid post-2014, they were actually already eligible. They were low-income seniors. They were part of the aged, blind, and disabled group. They just couldn't get through the bureaucracy of signing up for Medicaid in their state, so that they were able to sign on because they were assisted by what are called streamlined enrollment protections, things that make it easier. You could say to people, we have to come every day or every week or every other month and show all your paperwork and show that you're still eligible. If people don't make those appointments, then they're considered to be no longer eligible. It's important to know with some of the technological tools now, states have good information in regard to eligibility, how the eligibility rolls go up and go down, and that is public information that you should be able to get from your state. Can be very helpful. Often if you see a big drop-off in eligibility rolls, it often has to do with they've put in new requirements, the states, and you should hold them accountable for that. So we talked about populations. We have the historical, the federal core populations, but states can really choose to consider other subgroups. What's important here is it just needs to be a group that can be legally enforceable definitions of who's in and who's out. some examples of where states choose to consider to do different benefits or different services to other subgroups are children exiting foster care in order to assist in that transition, the youth population, adults caring for a disabled family member, the state not wanting people to be in nursing homes for the high cost and lack of community integration, wants to support adults who are caring for a disabled family member. So I may no longer continue to work because I'm caring for my disabled family member. I may be eligible for some benefits there. States have historically done special groups, people experiencing homelessness. Utah has done a lot of that, or people in addiction treatment, wanting to be able to ensure that they can access addiction treatment. While most policy and financing decisions at the state level are broken down by those 4 core groups we talked about, if you're thinking about advocating with your state for people experiencing homelessness, people in addiction treatment, there is precedence for that, and we're happy to share some of those details with you. And, oops, no, missed one. Thanks. We're back. You can also think about this as and this gets more and more complicated, these are your 10 essential health benefits. As some of these change, states may say, and if ACA is repealed and we lose the guarantee of these essential health benefits, states can say, I'm going to ensure that mental health and behavioral health treatment, for example, is covered for my age of blind or disabled population and my seniors population, but maybe it's not covered for my expansion population. These are ways that states can save money. States can take any one of these benefits if we lose the essential health benefits protection and say, we're not going to offer these services. And we talked about how states need to save money when you offer fewer services to a particular population group. That's an opportunity for the states to save money. It's also an opportunity for people who desperately need care in order not to be able to get it. So that's a piece that you have to watch very closely what the state may or may not be doing. I really think about it, and this is for folks who've worked in the homeless world for a long time, it's very easy to think about states, and this comes from the governor's leadership on down, going to have a perspective of we are trying to screen in, we are trying to make sure that people get the coverage and the care that they need. They can do outreach, they can do engagement, they can make it easy, or people can screen out. We can say there are people that we want to have coverage and there are people who, if they can figure out how to get in, that's okay. There really is a basic strategy. We've seen states where they put in a significant number of new requirements for individuals to have to prove that they're eligible for coverage, and then we've had the county offices or the state offices that sign you up for coverage be just absolutely staffed, deprived of staff, so that there isn't the staff there who can sign you up for coverage. Under ACA, a lot of this is still required to be online, but these are enrollment protections that could be lost if we lose the protections of ACA. This is going to be really important for working with vulnerable populations, or if you're working with people on the street, people experiencing homelessness, et cetera, because the more bureaucratic hurdles you put between people and their benefits and their coverage, the less likely it is that they're going to get services that they're entitled to. I'd like to say you can put in more and more hoops and make it harder for people to get that care and that coverage, and a lot of the folks that we work with are just not good hoop jumpers. If they have to jump so high and so far and so often, they're not going to be able to get the benefits and services that they're entitled to. If you're serving them in your supportive housing program, if you're serving them in your healthcare for the homeless clinic, each one of these bureaucratic hurdles becomes more work for your staff, more administration, and more of a challenge to ensure that people get the services and supports that they need. So really watch how the state is looking at this, what their fundamental assumptions are. Are they trying to screen people in and make sure that they get the benefits, services, and coverage they need, or are they trying to screen people out? Medically frail is an idea. I shouldn't say it's new, it's not, but it's an idea that comes from when someone comes in and says to the office, the county assistance office or the welfare office, the state office, and says, I think I'm eligible for Medicaid. It's because I have a disability, but that disability hasn't been proven yet. People go into what's called the medically frail category. They need to be looking at that disability but they have a very short time frame very short time window in order to prove that they are disabled. Individuals can self-declare as potentially medically frail. This is how Indiana does it. Each state does it differently, and it behooves you to look up how your state does this. I'm happy to share some websites that summarize all of this information. In Indiana, the managed care entity or the managed care organization has to verify status within 60 days. Often that means you need to go to a doctor, and that means you need to get certain forms filled out. Other states like Texas require that's attached to your supplemental security income or other disability income, et cetera. If you can prove that someone else has determined you're disabled, then they will put you onto Medicaid. But as folks know, those are very, very high bars to reach, particularly for people experiencing chronic homelessness, so this verification becomes more difficult. If the medically frail status isn't verified, the member's no longer eligible for these benefits, and they're transferred to a different service. Annually, and again, this is Indiana, each state does it differently. The managed care must confirm the qualifications for the medically frail status, and the state verifies that status every year. You can put those verifications in more frequently, and you'll lose more people not being able to make that through, and you have to make sure that people have access and coverage to a doctor. Historically, people have been in what we like to call catch-22 situations, where on the one hand, you're medically frail, you need the insurance, on the other hand, doctors, physicians, medical professionals aren't going to be able to see you if they're not going to get paid until you get that insurance. So it puts people in really difficult situations. The more bureaucratic you can make this process, often this is what screens people out as well. But it's important to know that with new data tools and under ACA, states have to report how long it takes them to go through this process. There are benchmarks and timeframes. This should be public information in your state. So look and see how long that process is. And if you see a big change in how long it takes people to get verified, that means that they're going without needed care and coverage. That's also something to raise with your state Medicaid offices. Cost sharing is another way. Often that Medicaid offices, state plans can make it more difficult for certain populations. And remember, states can put in different requirements for different populations. Cost sharing means they can put in premiums to help keep your insurance, meaning what I have to pay every month. In Indiana's plan, you have to make a payment every month, and your coverage doesn't count. You're not covered until you make that first payment. So the first time you go to the county welfare office and say, I need coverage, this is my income, this is my disabilities, et cetera, it doesn't start there. It doesn't start until coverage doesn't start then. It starts when you make your first premium payment. Cost sharing also means that higher deductibles can come in, and then more and higher copays. But in a very important study I have highlighted here, research shows that cost sharing for the low-income populations, the states don't save money because they've collected a significant amount of these copays. They don't save money from the deductibles and premiums. They save money because more and more people forego care. Again, I go back to all of the hoops you have to jump through in order to get coverage, support, services, and care. The more hoops you put in, the more people fall out and fall away at every turn. I might also say that often it's only people with either the most difficult health challenges or people with the most, shall we say, the most vehement advocates are able to maintain their coverage through a lot of these hoops, through a lot of these challenges, et cetera. And also in the notes, there's the brief and also a Medicaid primer. Highly, highly recommend any information from the good people at the Henry J. Kaiser Family Foundation. They've done the research, they've organized the information in a way that's easy for us. Lots of resources there. States are also, these are 4 states that are using what we call alternative models: Arkansas, Iowa, Montana, and New Hampshire. Whether it's some of these states that have put forward not a traditional Medicaid expansion, but they've done through a waiver, saying that they're going to cover certain numbers of people, saying that they're going to cover alternative benefit packages, things of that nature. All of these states have done it with alternative models. If you're in a state with an alternative model, there's going to be a little bit more research required on your part to show what benefits are covered, what populations are covered, how they're covered, what they're entitled to than these traditional plans. Right, there we go. Let's talk about some also things states can do that make coverage and access to care harder to access. And we're going to highlight Wisconsin. Wisconsin in the last week or so has put in a waiver requesting a significant number of these requirements. Time limits are in place. Both Arizona and Kentucky have both requested historically, or Kentucky just recently, time limits. I don't know the number for Kentucky. I know Arizona in the fall requested a 5-year lifetime limit for Medicaid coverage for individuals. So you may be on for 5 years and then, or you may be on and off for 5 years, churn they call that, et cetera, but you can't have coverage for longer than that. Very concerning to folks who have a variety of medical conditions. States can require health savings accounts. Health savings account is this idea that you should put away money in a tax-free way that helps you pay for your premiums or your deductibles, your copays, other things related to your health care. If you have a very healthy income, that's a great idea, and it gives you more of your money tax-free. If you live paycheck to paycheck, as many people who are on Medicaid do, there's really no extra money each month to set aside to put in for these health savings accounts. It's also important to note that Indiana requires that if you do not make your required health savings account payments, what they call power accounts, you can either lose your coverage or be pushed to a lower benefit package coverage. These are all strategies that states can use. Wisconsin is requiring drug testing, despite good research showing that drug testing catches very, very few people. It's always less than 1% of the people that are found to be using drugs while they were receiving public benefits. And it's often also, it costs more money to administratively manage the program. It costs more money to give out the drug test than the state actually saves in kicking people off of benefits because they've been found to have these challenges. Premiums, as we talked about a little while ago, work requirements. Maine, Wisconsin, Arizona, Kentucky are all putting forward work requirements. Interestingly, in the fall, and this was approved by the Obama administration, Montana added voluntary options and also resources to help people get jobs. They added good information for people who are coming in for Medicaid about child care, about training, about transportation benefits. So there are ways to help people get jobs, but cutting off their health care if they don't follow through with whatever the state is requiring is usually not one of them. And it's important to know that states can structure these in a different way. You can be required to get a job. You can be required to be in training. You can be required to ensure that you are doing everything you can to find a job. But how states do that differs at a very detailed level, state to state, and you will see, depending upon how that's done, you will see more or fewer people lose their coverage in that manner. So if your state does get to a point where they have approved work requirements, it's going to be very important that your programs, your agencies, the people in your community understand exactly how that's being implemented at the county assistance offices, what resources, what information they have, and watch that closely. If you're in a community that's lucky enough to have a good legal aid system, to have a good health law project, things of that, those can be some really effective allies in addressing these issues. States could also put forward what's called more frequent redetermination. This is the idea of changing some of the streamlined enrollment protections we have. This is the idea that you have to come more often and more frequently to the office and prove you didn't just win the lottery and prove you don't have income that puts you out of the Medicaid coverage arenas. So long list of things. This is what we've seen so far. States may be cooking up some new ideas in regard to how to limit coverage, make coverage and care access or more difficult, how to save money. Again, I go back to, and we've seen this in the homeless system, are we screening people in or are we screening people out? What's the basic philosophy that's being pushed from the highest levels of state government down to the local offices, et cetera, and see what that perspective is and keep vigilant. Finally, ending up here, what should we watch for over the next few months? We should watch Republican governors. This is Ohio Governor John Kasich, who's been a very vocal proponent of both Medicaid expansion as well as assistance for people with behavioral health challenges. Watch Republican senators from states who've expanded Medicaid. Your state should have a way to sign up for notices from your state Medicaid office in regard to what changes are made, what waivers are being submitted, the ability to comment on waivers, as we talked about. Et cetera. Also know your advocates, know who your lobbyists are in the state capitol. A couple of national groups that we recommend you follow is Community Catalyst, Families USA, and Center for Budget and Policy Priorities is doing work what they call Sabotage Watch. So There's very broad, gross, if you will, ways to do this. You can just repeal the law, or there are death by 1,000 cuts. If this is being done by states, they've tried to repeal the law. That, as we all know, didn't happen. But there's a lot of death by 1,000 cuts that can happen at the state level. And we've tried to talk about some of those. We'll certainly try to keep people updated if any of these change or there's any new strategies that come up here. But again, there are people in your state capital who watch this closely, who attend these meetings, and we highly recommend that we look at some more strategies for engaging with those groups, for supporting those groups, for going to their rallies, for signing on to their sign-on letters, things of that nature, and then watch also Families USA, Community Catalyst, some of these other organizations. First Focus, they are all looking at ways to engage people around the various political conversations that are happening now around healthcare. With that, I will let people know that, again, because we're almost at time, we are not going to take questions, but I do ask that folks, if you do have any questions, please email me at marcella.mcguire@csh.gov. Also follow us on Twitter through CSH, National Alliance to End Homelessness, and the National Healthcare Council. We thank everyone for their attendance today, and we thank you for all of the great work you are doing and all of the great work that we hope you are beginning and educating yourselves and preparing and planning to do in your state capitals with your state Medicaid agencies to ensure that both your programs, your community, and most especially the people that you work with every day can still have the access to care, health care, the access to health coverage that we know they all need. So thank you very much, and please be in touch with any questions. No, one more slide, I think I need. And please join us, should have said this, please join us in 2 weeks for 30 minutes on proposed changes impacting Medicaid enrollment and the continuity of benefits. That'll be Monday, May 8th at 1 o'clock. And your presenter will be Barbara DiPietro from the National Healthcare for the Homeless Council. So thank you very much. We're really excited and look forward to talking then.